Hi everyone, we are starting with epidemiology today. This is the one lecture that I told you in class I wanted to do a voiceover for because it can sometimes be a difficult topic to kind of get a grasp on, but it is the essence of the science of public health, and so I think it's really important to make sure that we are capturing those concepts today. So here we go. So what is epidemiology? And by the way, short term for epidemiology and public health is epi, which took me a while to get used to because I'm used to thinking of epinephrine when I say epi, but now my brain has fully switched and epi is epidemiology. So basic science of public health, it comes from the words epi, demos, and logos, which together essentially mean the thought or the thinking of what happens or what comes upon people. And so that's essentially what it is we're studying the occurrence and the distribution of different health-related states or events that happens in specific populations. So, sorry about that. So essentially what epidemiologists do is they are asking the basic W questions about a sort of disease or illness state, something that affects health. So they're essentially asking what is happening, who is it happening to, when is it happening, where is it happening, why is it happening, so that ultimately we can figure out interventions to bring about health again and rectify the situation. I bring up the wheel. I'm going to continue to bring this up throughout our class. I just want you to be very familiar with this, as this holds the 10 essential services of public health clinicians, not just nurses, but all public health clinicians. And so I just want you to look at this for a second and think, where would epidemiology fall into this if this is about investigating patterns of disease? You can see the word investigate with diagnose and investigate. So hopefully that's where you are able to find that, yes, epidemiology goes there, so that going on to the next essential service, it can inform how we educate and empower our communities to rectify situations and find better health. So I got to give you a little history. I do love history. As you saw, I brought in a historian recently to our class. So I think it's really important to kind of understand where this all started. So first person I want to talk about is Dr. John Snow. He was an OB actually in London in the 1850s. He is who we consider to be the father of epidemiology. And while he was working on developing anesthesia for childbirth, he actually kind of fell into a whole different field. So basically he was living in a neighborhood of London called Soho, and in 1854 they experienced a massive cholera outbreak. And in that day and age, the medical professionals and scientists of that time thought that cholera was caused by breathing in bad vapors. And they had no thought that it had anything to do with your GI tract, even though symptoms were related to the GI tract, right, with major vomiting and diarrhea and dehydration. So he advocated that perhaps cholera was actually an intestinal disease. It had nothing to do with our respiratory system, and that perhaps it was even related to drinking bad water. So he decided that he was going to prove his theory correct by doing what we still do today in epidemiology, by tracking cases, mapping them, and trying to find out causes based on where he was finding the cases. So what he did is he was able to track that a whole bunch of cholera cases were happening around this water pump that was in the middle of a street called Broad Street in the middle of his neighborhood, Soho. And so what he did is every new case of cholera that would come up, he would track that case to see if that person had gotten their water supply from this certain water pump. He did find that there was a prison right near this water pump that had no cholera cases, so that kind of messed up his theory at first. But then as he investigated further, he found out that this prison actually had their own well for their water supply, and so they weren't using that pump. Another unusual case that came up was that there was a woman and her niece who lived quite far from this pump but developed cholera. And after interviewing multiple family and friends of this woman and her niece who ended up dying from cholera, he was able to find that this woman used to live near the pump, and she loved that specific Broad Street pump water so much that even when she moved away, she would have people bring her bottles of water from that pump. Her niece was visiting her, brought her one of those bottles, and then she died the next day. And actually, her niece didn't die. Her niece wasn't a part of the water. It was just this woman. So, and this is something that epidemiologists, specifically at the county health department here in San Diego, do. When they hear about certain cases of communicable diseases, they will investigate, they will map, and then they will interview family and friends to kind of find out a possible source. So finally, what Dr. Snow was able to discover was that a woman who had a baby with cholera would wash this baby's dirty diapers just up the street from the water pump. And so, as you can imagine, in dirt streets back in the day, that cesspool of sewage from this baby's dirty diapers would kind of creep its way through gravity down to the water pump area. It was about 3 feet from the water pump when he was able to find it. So you think that would be enough evidence for people to finally start believing Dr. Snow, but no, took even more. So finally, I guess he was able to get the attention of the city authorities though. And so what they decided to do was take the handle off the water pump in the street and see if that made a difference. And sure enough, all the cholera cases in that neighborhood completely halted. So he was found to be the victor, and people finally were able to figure out what cholera was all about. So the next case of an epidemiology hero is our own Flo, as we lovingly call her in the School of Nursing here, Florence Nightingale, our mother of nursing. One of the major things that she did when she helped soldiers in the Crimean War in Turkey, also around this era, was that she discovered at the time that more soldiers were actually dying from infectious disease than from their own war wounds, which is a horrendous statistic. And so she went about improving sanitary conditions for these soldiers so that they would not die from infectious disease and that they would have a better chance of surviving the war. She did simple things like encourage the use of hand hygiene before and after surgeries, between patients. She made sure that soldiers had clean bed linens every day, that they weren't sitting in their blood, their feces, their urine. She opened up curtains and windows and brought in just clean air and sunshine. So she did all of these really basic things to improve environmental conditions because she was looking at death rates and why was this happening. She was kind of tracking all of that and figuring out basic causes. And by doing these things, she improved the death rate of these soldiers by 2/3, which is pretty incredible. So I want you to be able to understand just some basic concepts and measurements within epidemiology. So I'll just kind of go through these pretty quickly. They're pretty self-explanatory. Morbidity, as you probably already know, when we talk about comorbidities, is the state of being diseased. So comorbidities are having different states of disease, different diseases. And then we have mortality, which is actual death. CDC puts out what they call the weekly Morbidity and Mortality Weekly Report, MMWR, and that kind of goes, it's a scientific journal that goes through all of the latest happenings related to epidemiology. Then we have the concept of prevalence. This is a really important thing that I want you to be able to understand and differentiate from the next term, which is incidence. So when we talk about a prevalence or a prevalence rate, we are talking about the number of current cases of a disease at any given point in time. So prevalence would just be the number of current cases. Prevalence rate would be a fraction, right? So it would be the current cases over total cases. We'll talk more about that in a second. And then we have incidence, which is different than prevalence, and that incidence is the number of new cases with disease within a population at risk. So incidence specifically looks at new cases over the total number of people who could possibly be at risk for that disease. We have life expectancy, which is something we'll come back to, especially when we talk about the U.S. healthcare system versus other healthcare systems abroad. This is a major health indicator that we use globally to kind of get a quick check on a nation's state of their health. And so this is basically predicting how long people will live in a given population. And then the last one I want you to know is attack rate. This is usually, well, not always, but oftentimes this is something that we refer to when we talk about foodborne illnesses or foodborne outbreaks. So it's basically, it's a fraction again, a proportion. So it's thinking of how many people were exposed to an agent, such as, say, a bacterial or viral agent that could cause food poisoning. Let's say you're at a restaurant on a given night and that agent is there. So how many people have been exposed over how many people actually develop the disease. So how many people develop symptoms and become infected. That would be your attack rate. We talk about disease distribution. 3 important terms that we talk about, and these may be familiar to you or somewhat familiar to you already. So when we talk about an epidemic, we're talking about a large outbreak. And oftentimes people think that in order to categorize something as an epidemic, it means you have to have a certain percentage of the population that's affected. But that just wouldn't be very helpful, because with certain diseases, you have a very small percentage of a disease at any given time, and so having you wouldn't need that large of a number or that much of an increase to all of a sudden warrant some concern. So the way that epidemics are essentially defined is having an outbreak that's just affecting a larger number of people than would be expected. And this was especially true with our Hep A epidemic. We're going to get into the numbers in a little bit, but within our local Hep A epidemic, it didn't affect that many people when you look at a percentage, but it was so much greater than what we have ever seen before. This is why we called it an epidemic. When we talk about a pandemic, we're talking about something like an epidemic, but that has gone worldwide in distribution. A few years back, we had the H1N1 scare around the world, and so that's an example of something that went pandemic, went globally. And then an endemic is something that tends to be a major problem in a given geographical area or in a certain population. An example of this would be malaria, which is endemic to Africa. So we know that if we're going to travel there, we need to take anti-malarial pills before we go and have preventive measures in place, because malaria has a constant presence in Africa. So something that was brought up in one of your assigned videos, and I just want you to be very clear about this. It is not a hard model, but just want to kind of make sure that we're very clear about how this works. This is our basic epidemiology model of how disease occurs. You have to have 3 things. You have to have an agent, you have to have an environment, and you have to have a host that makes these things happen. So if we walk through the example of hepatitis A, the agent is the virus, right? So the virus is hepatitis A. Hepatitis A can affect a host, such as humans, but needs a certain environment to do so. So the environment is the really important piece here. If we can affect the environment, then we can prevent illness or disease, right? So in the case of Hep A, with humans here in San Diego, the environments that allowed this to kind of spread and infect people rapidly are unsanitary conditions, right? Poor hygiene, because hepatitis A travels in a fecal oral route. So if we break that down even further, that's people who are going to the restroom, are not able to clean their hands properly after, and then are putting things into their mouths, eating, right? So when we have unsanitary conditions like that, we're not able to wash our hands, and when we're living in really close quarters that are kind of dirty, then this can happen. So you might remember that we had hand washing stations that were set up all around the city for a certain period of time, and that was to help kind of cut down on that unsanitary environment that allowed the agent, hepatitis A, to spread. So I think the best way to really dive into epidemiology is to kind of do a case study and talk about how we use the principles of epi to inform our health practice. And again, the questions that we're asking are: who is being affected? What is affecting them? When are they being affected? What are the time periods? Where is it happening? So what is the geographic location where we're most at risk, and why? Ultimately, why? And this is always so that we can inform the way we educate the public, the way we write our policies, change our policies, and how we meet people where they're at when they have these conditions. So Public Health Now, one segment that is very relevant right now is the opioid epidemic. So I'm going to click here and show you. This article is not entirely new. It was in October of 2017, but it just does a really great job. I'm not going to read it all for you, but the link is here if you want to look into kind of a crisis that took years in the making. So an example here, it talks about how overdoses are the leading cause of death for Americans under 50, killing about 64,000 people last year. So that would have been in 2016, doing so at a pace faster than the HIV epidemic did at its peak, which is pretty staggering. President Trump has declared the opioid crisis a public health emergency, although funding has been a little bit slower to follow. So there's a lot of different snapshots here, different populations that are affected. Babies, neonates are a huge one, right? We're having an increasing number of babies born with opioid dependence. Also, it shows here an increasing number of toddlers, young children being found unconscious or dead after getting into mom or dad's drugs. This map is a really great one here where it shows the red is the major overdose deaths and how in 1999 there were hardly any bits of red in our country, and then it's just dramatically increased over the last 20 years. We'll go through some more maps in a minute. Let's see if there's anything else I wanted to show you here. This is something I don't have time to go over, but you can look here. They talk about the issues that detention centers are facing and how methadone treatment continues to be a really important piece of the puzzle and how we recover these peoples. Okay, I'm going to stop there and go back to the PowerPoint, but it's a really interesting article if you're interested in learning more about that. So what's the problem? The problem is the opioid overuse that is happening across our country, causing deaths, causing babies to be born with abstinence syndrome, and causing a lot of problems. I think this article, I know there's other ones that go into it, the problems where our foster care systems are being flooded with kids who are being taken away from parents who are addicted to opioids. So it's just becoming an issue on so many levels. Here's another graph. CDC is my very best resource for all things public health, specifically epidemiology. So this is looking at overdose deaths involving opioids over the last 20 years. This shows from 2000 to 2015. And you can see that it has just skyrocketed in the last 10, 15 years or so. And if you look specifically, all opioids are going up, but what's really strikingly going up is heroin and other synthetic opioids such as fentanyl. So to look at a little more data here, again, I show you a lot of these resources because I think a big part of public health is just diving into the resources and knowing where to find information, not only for you and how to get data, but also for your clients. So when we look here at the overdose epidemic, there's so many things I could go to, but first what I want to show you is just overall drug overdose deaths. This map here shows where we've had statistically significant increases in drug overdose death rates from 2016 to 2017. So our state is in there where we've had major increases over recent years. But then if we just look at overall deaths, and the most recent data is from 2017, just take a look here for a minute at where we have in the dark red the highest number of overdose deaths. A lot of this is being centered in the Appalachian region, Kentucky, West Virginia, Tennessee, and then up into the Midwest and the Northeast. And then we have a whole bunch in the Southwest too, right, with Arizona, New Mexico, Nevada, Utah. So important to kind of look at, okay, where is it being focused, right? That's an important piece of epidemiology because where the most issues are occurring is then where we want to focus the majority of our resources. But what I think is also interesting is if you look over here on the left, I'm going to go to the U.S. prescribing rate maps. This is really interesting because how much of it perhaps is connected to actual prescriptions, legal prescriptions of opioids. And if I look at the most recent U.S. state prescribing maps for 2017, pull this up here a little bigger, where are we seeing the most prescribing? Well, we are seeing it some in West Virginia, definitely Kentucky, Tennessee, Alabama, Missouri, Louisiana. So we're getting close to that area. So it's very closely connected to where we're having a lot of the deaths. So just an important piece to look at when we're looking at data. So what is being done, right? So how is this informing practice? We're graphing it, we're mapping it, we're figuring out who it's happening to, where it's happening to, what are our time frames, how frequent, how much has this been increasing over how much period of time, and then what are we doing about it, right? So this is just, I like this little graphic. It's for Pennsylvania, but it's just kind of a great snapshot of their crisis, and then showing how you could post this as a health education piece in different places. So what is being done? I have first a link for what's being done on the national level. So this is the National Institute on Drug Abuse. This is a great resource as well. It kind of talks about how this has been happening. So come up a lot of reasons on the why, which there's a lot of different theories as to why this is happening. Definitely overprescribing is a piece of that. What do we know about this? People who, interesting, when we looked at the heroin rates really going up, well, it says here that about 80% of people who use heroin first misused prescription opioids, so can be that gateway to heroin, which then causes a lot of the drug deaths. So here's where I wanted to show you what is the Health and Human Services and the National Institute of Health. What are we doing about it? 5 priorities. So they want to improve access to treatment and recovery services. They want to promote use of overdose reversing drugs. So that would be where we're trying to get more Narcan out in the streets and get lay people trained in Narcan. How can we strengthen our understanding of the epidemic through better public health surveillance? Surveillance is exactly what we've been kind of going over. How are we tracking these cases and kind of getting a better understanding of where and why they're happening? We need more support for research on how do we manage people who are not only addicted, but who are just in pain, whether it's been a surgery, whether it's a chronic pain issue, and how can we find better pain solutions that aren't always going to be opioids? And that kind of goes with the number 5 too. How can we have better practices for pain management? And that actually ties into the next one. I wanted to show you on a local level what we're doing. This is an article that came out of UC San Diego Health. Talked about the 6 ways, this came out in December, how they're combating the opioid crisis. So they talk about having better guidance for primary care providers, helping them get a better understanding of how to manage pain, because they're generalists and that is not always their focus, but yet they're usually the frontline people that are being asked to prescribe pain medication. Giving providers, ways to minimize the opioid prescriptions, figuring out other mechanisms of dealing with pain, but also one of the things it talks about at the top here was that their pain management team rewrote their pain order sets to optimize non-opioid pain management options so that opioids weren't just the automatic go-to off the bat. Making sure that providers always check the specific database that California has called CURES. It's maintained by the California Department of Justice, and it tracks all controlled substances prescribed in the state, so that if we're checking that, we're able to keep patients from shopping around and getting different opioids from different providers. Helping patients understand better how to manage their opioid use so that it doesn't eventually turn into an addiction. Another big thing that's happening a lot now is providing secure places for people to dispose of their opioids. I just read an article today that was talking about how a new problem that people are realizing is that open houses, so the real estate industry is getting involved because they're recognizing that open houses, when people are trying to sell their home, are a time when people will often come in, pretend like they're potential home buyers, and then they will go and steal prescription medication out of the homes, out of people's medicine cabinets. So realtors are getting involved in this as well. And then how do we improve access to medication-assisted addiction treatment? So this is where it's really big that we provide a methadone regimen that is well followed, and patients can kind of find a safe way to come off of their addiction. So I want you at this point to stop this, voiceover and click on this link here and watch this video. It's about 10 minutes. It's a very passionate guy talking about specifically incidence versus prevalence. And I think I have had to watch the video numerous times, but I think it's really important that you watch it at least once, if not twice or more. Take some notes, make sure you really understand those concepts. And then what I'm going to do after you've watched this video is walk you through some practice exercises so that you really do get a good handle on epidemiology. Okay, so let's practice. I'm going to use our local example of the Hep A epidemic. And I first want you to work on calculating a prevalence rate. So you may need to get a pen and a paper if you don't have that already. And I want you to come up with the prevalence rate. So here's the prevalence rate. Here's the formula for it. Number of cases of a disease that's present in the population, and then number of persons at risk of having the disease. So if I tell you that there are currently 89 Hep A cases in San Diego County right now, what would the prevalence rate be? Hopefully you're asking, well, I don't have all the information, right? Because I have not given you the denominator. I've given you the numerator, which is 89. But how many people are actually at risk? Well, that would be our San Diego County population, which is roughly 3 million. So now you can plug in those numbers and go 89 over 3 million. You get a really tiny number. And then you multiply that by 1,000. This is what we normally do, especially when the numbers are so small. And ultimately, you should have 0.0296. It goes on and on. And you would say that that's the prevalence rate per 1,000 people. Okay. So for the incidence rate, then what you want to do is you want to look at what are the number of new cases, right? So if I tell you that the incident rate is that what's the incidence rate if there are 6 new cases of hepatitis A in San Diego County in May? So this month there have been 6 new cases. What's our incident rate? Well, what's the bottom number? We know this top number is 6. Well, what's the bottom number? You might think it's 3 million, but actually it's how many are still at risk. And if we already have had 89 contract the disease prior, right, that was our prevalence rate. Now we have 6 new ones for this month. So the bottom number is actually 3 million minus 89, because that is who is still at risk in San Diego County. So that number comes out to 2,999,911. You put that number on the bottom, you put 6 on the top, then you get a really small number, you times it by 1,000, and then your final number, your incidence rate, is 0.002 per 1,000 people. See, I'm telling you, these rates for hepatitis are quite small, but yet we consider it an epidemic because it was so much greater than what we commonly experience in San Diego County. So then what I want you to do is add up the number of new cases to the existing cases. So that's 6 to 89, and you get 95. Well, here, and these are actual numbers from when the epidemic ended in San Diego, it says the total number of cases were 592, but I'm telling you that it's 95. So what happened? If the total number of cases over the entire epidemic of about 2 years was 592, but currently there's only 95 cases, then what happened? What happened to the rest of those cases? And hopefully you remember from the video that man talked about, there's only 2 things that allow prevalence to drop. Do you remember what they are? Death and cure. So, and we can look at the numbers for death here. There were 20 deaths. So if we have 592 total cases, but we had 20 deaths, then that means 572 people were cured, right? Or at least they didn't die. So that is how we come up with a prevalence rate that lowers. It can only be lowered because people either got better, they were cured, or they died. So that is all I have for you on epidemiology. If you need to keep practicing stuff, you can go back and kind of review these slides without my talking. But I hope you've gotten a good overview. As for the rest of the lectures, I don't have voiceovers for the other pieces of STIs and other communicable diseases and vaccine preventable diseases. My hope is that the PowerPoints are pretty straightforward and that you can gather what you need to know from reviewing the PowerPoints, reviewing the readings and the videos as well. So have a great week.